Welcome to the Week 7 lecture. You should have already read these 2 chapters by now. Let's get started. The endocrine system is our slower messenger, as the nervous system is much faster. The endocrine system uses glands to secrete hormones in the blood and surrounding tissues for the messages it sends and is longer lasting. This week we will learn what can go wrong with the endocrine system. The hormones of the endocrine system travel around the body looking for target cells or cells with their specific receptor on their cell surface. A hormone can only affect cells that have a receptor for them on their surface. Let's review the glands and the hormones they secrete. First, the anterior pituitary secretes TSH, or thyroid stimulating hormone, ACTH, or adrenal corticotropic hormone, FSH, or follicle stimulating hormone, LH, or luteinizing hormone, prolactin, and growth hormone, or GH. The posterior pituitary releases oxytocin and ADH, which is also known as vasopressin. The thyroid gland secretes T3 and T4, and the thyroid hormone, which are the thyroid hormones. It also secretes calcitonin. The parathyroid gland secretes parathyroid hormone. What do these hormones do? TSH stimulates thyroid hormone release from the thyroid gland. ACTH stimulates the secretion of glucocorticoids from the adrenal cortex. FSH stimulates the release of estrogen and helps in follicle and sperm development. LH helps in ovulation and progesterone release. Prolactin stimulates milk production. Growth hormone stimulates body cell growth, protein synthesis, and catabolism. ADH causes free water reabsorption at the kidney and contraction of blood vessels. Oxytocin stimulates uterine contraction and milk ejection. T3 and T4 help in increased metabolism, oxygen consumption, and growth and development. Calcitonin decreases serum calcium, while parathyroid hormone increases serum calcium. In the adrenal cortex, we have aldosterone, which causes sodium reabsorption in the kidneys, and also water will follow by osmosis. Cortisol is also released at the cortex and regulates carbohydrate metabolism and stress response. In the adrenal medulla, we have epinephrine and norepinephrine, which help to stimulate the sympathetic response of fight or flight. In the pancreas, alpha cells release glucagon, which increase glucose levels in the blood, and the beta cells release insulin, which decreases glucose in the blood. The hypothalamus is the master gland and controls the function of the endocrine system. It does that by releasing hormones sent to the pituitary gland along with nerve impulses. The releasing hormones stimulate the anterior pituitary while the nerves stimulate the posterior pituitary. Inhibitory hormones will inhibit hormone release and also are from the hypothalamus. The pituitary is made up of the anterior portion, or the adenohypophysis, and the posterior portion, or the neurohypophysis. The anterior pituitary makes its own hormones, while the hypothalamus makes the hormones for the posterior pituitary, and they're just released from there. The hypothalamic and pituitary hormones make up an important negative feedback system for the body to maintain homeostasis. If there's not enough of a hormone, say the thyroid hormones, then both TSH from the anterior pituitary and TRH from the hypothalamus will work to get the thyroid to release more thyroid hormone. And if there's too much thyroid hormone, then both TSH and TRH will decrease. This is an example of a negative feedback mechanism in the endocrine system. The endocrine system can have errors with deficiencies or excess hormones. Some patients may also have issues with the hormone receptors. The glands can have less hormone production due to an autoimmune attack or because of ischemia or a genetic issue. They can also have overproduction due to the same causes. Hypopituitarism or panhypopituitarism is most commonly due to a pituitary adenoma and is one of more undersecretions of pituitary hormones. Now, sometimes a pituitary hormone can oversecrete hormones and undersecrete them. Look at this pituitary tumor here on CT scan highlighted in purple. Other problems with the pituitary gland can include strokes, hemorrhages, and genetic issues. Symptoms with pituitary tumor can range from temporal visual fields loss to headache to loss of fertility or glucose issues, acromegaly, seizure, or other symptoms. Imaging is done with CT scan and a better picture with the MRI of the head. Sheehan syndrome or is ischemia or infarction of the pituitary gland, resulting in destruction of the gland and loss of pituitary hormones, which have to be replaced. This is a form of panhypopituitarism. It results from loss of blood to the pituitary during hypotension in pregnancy from hemorrhaging or enlarged pituitary and small cell ataxia, causing the gland to be crushed and injured. Gigantism is way too much growth hormone as a child before puberty and before the growth plates are closed. This can be due to a pituitary tumor. Acromegaly is also too much growth hormone, but occurs in adulthood after puberty when the growth plates have already closed. So only certain areas like the forehead, nose, hands, and feet get bigger, and the patient is not taller than usual. This too can be from a pituitary tumor. Dwarfism is a lack of growth hormone in childhood, and we look for this with the use of pediatric growth charts like this one. If the child is much shorter than they should be for their age, then we will test for a lack of growth hormone. This can be easily replaced in primary disease, but if there's damage or a lack of growth hormone receptors, then this will not work. Diabetes insipidus is the other type of diabetes besides mellitus. Diabetes just means polyuria or making a lot of urine. DI deals with ADH, not insulin, and glucose. So do not get them confused. Diabetes insipidus can be central or lack of ADH released by the posterior pituitary, or can be nephrogenic and have a lack of ADH receptors in the kidneys. Both result in large amounts of free water lost in the urine, as ADH reabsorbs water for us normally. Symptoms include polydipsia and polyuria, but no polyphagia like in diabetes mellitus. Dehydration with hypernatremia can result if not kept hydrated. Treatment for central DI is ADH or vasopressin. SIADH, or syndrome of inappropriate ADH, is too much ADH. It causes the body to be diluted with excess free water. Fluid restriction is the only way to treat this to allow ADH to normalize. The thyroid is anterior to the trachea. It produces thyroid hormones and calcitonin. It helps regulate body metabolism and calcium, as we mentioned earlier. If it becomes diseased, then it can make too little or too much thyroid hormone. Enlarged thyroids are called goiters. Goiter is an enlarged thyroid that can come about from excess or underuse of the thyroid, usually more in hyperthyroidism or from lack of iodine in the diet. Examination of the thyroid involves palpation from the front, then you stand behind the patient and have them swallow so you can feel for nodules or masses. Ultrasound of the thyroid can be done if you find a nodule or mass to fully investigate it. Thyroid biopsies can also be done by ultrasound fine needle aspiration to look for cancers and other pathologies. If concerned about a nodule being overactive like in hyperthyroidism patient, then you can do a radioactive iodine uptake scan. Hypothyroidism is underactive thyroid disease, and primary is the most common cause. Hashimoto's thyroiditis is an autoimmune cause of this disorder. There are other causes too. Symptoms include cold intolerance, weight gain, lethargy, fatigue, memory problems, and poor attention, puffy face, and hair loss, as well as some others. TSH will be elevated, and if Hashimoto's, then check antithyroglobulin and antithyroperoxidase antibodies. Treatment is to replace the thyroid hormone. Hyperthyroidism is overactive thyroid, and there will be thin with palpitations. Exophthalmos or bulging eyes as seen here. TSH will be low or zero, and T3 and T4 will be elevated. Untreated hyperthyroidism can lead to thyroid storm. These patients should be given antithyroid medications like propylthiouracil or PTU to block the effects of thyroid hormone, along with beta blockers. Testing for a hot nodule using radioactive iodine uptake may show an area that can be removed without damaging the entire thyroid with radioactive iodine treatment, causing the patient to be on thyroid hormone replacement for life. Thyroid storm is hyperthyroidism, untreated or overdosage of thyroid hormones. It can be life-threatening and lead to tachycardias and dysrhythmias. This is a medical emergency. Compare hypothyroidism with hyperthyroidism. Hypothyroidism patients are slow, sluggish, gaining weight, low heart rate, constipated, puffy face, depressed, and lethargic. Hyperthyroidism patients are skinny, losing weight, have nervousness, anxiety, tremors, muscles cramps in the legs, palpitations, tachycardia, atrial fibrillation, and exophthalmos. Hypothyroidism has increased TSH and decreased thyroid hormones, while hyperthyroidism has decreased TSH and increased thyroid hormones. Remember, the pituitary is trying to use negative feedback to return the body to homeostasis here. You need to be able to tell the difference in a patient with hypothyroidism or hyperthyroidism for the exam. A radioactive uptake scan is used to look for the cause of hyperthyroidism. The patient takes radioactive iodine, and then a scan is done to see where it goes. If the thyroid is overactive and the portion that is overproducing thyroid hormone will use the iodine first. If there is a nodule, and if it's hot, a nodule meaning it's active, or if it's a cold nodule meaning it's not producing thyroid hormone. Removing the hot nodule will cure hyperthyroidism. If it's like Graves' disease, then the entire gland is active. Then using medications to block the thyroid hormone at first, then removing the ability of making thyroid hormone with radiation treatment will then cure the disease, but the patient will then become hypothyroid and need thyroid replacement. The parathyroid glands are responsible for making parathyroid hormone. There are 4 pea-sized glands just posterior to the thyroid gland. PTH is directly correlated with calcium levels. So too much PTH will give you high serum calcium, and too little will cause low serum calcium. Remember, calcitonin does the opposite and is made by the thyroid gland. Hypoparathyroidism is rare, but can occur with thyroid gland removal, as one can accidentally get the parathyroid glands as well. Replacement parathyroid hormone would then be needed. The patients will have hypocalcemia symptoms, as we discussed last week, including your favorites, Chavostex and Trousseau signs. Hyperparathyroidism comes from parathyroid tumors and will cause high calcium levels or hypercalcemia and all of the symptoms that go along with this: calcium, kidney stones, muscle weakness, osteopenia, pathological fractures. The diagnosis is made by a sestamibi scan. It's used to detect parathyroid tumors, surgeries to cure, and efforts to lower serum calcium levels. The adrenal glands are like little hats for the kidneys. They make several hormones that we need to survive. The medulla makes cortisol and aldosterone along with some androgens, and the cortex makes epinephrine and norepinephrine. Lack of ACTH from the pituitary can result in a lack of cortisol in the body. This can result in adrenal insufficiency or hypoadrenalism. Patients with this condition can have fatigue, hypotension, hypoglycemic, and have electrolyte abnormalities, anorexia, and confusion. These patients have to take oral corticosteroids their entire life. President Kennedy had Addison's disease and was on oral corticosteroids. This may help you remember this disease. Hyperadrenalism is overactive adrenal gland production. It can be due to oversecretion of ACTH from pituitary tumor, for example. Too much cortisol can cause Cushing Syndrome, and this is most commonly from taking oral steroids over a long period of time. Patients with COPD or emphysema, for example, must be on chronic oral steroids for years, and this can result in Cushing Syndrome. The octreotide scintigraphy is used to detect ACTH-secreting tumors in the body. ACTH can be made by certain cancers and tumors other than anterior pituitary tumors, and this can lead to adrenalism or Cushing syndrome. See this image here of a small cell lung cancer called a neuroendocrine tumor that secretes ACTH. Cushing syndrome is from overuse of oral corticosteroids for years. Sometimes it may be from an ACTH-secreting tumor. These patients will be obese, have a classic round moon face, and possibly a buffalo hump on the back. They may have stria or stretch marks from weight gain and loss. Hirsutism is common, as fat increases along with possible ACTH increases will increase androgen production as well. We touched on this before in week 4, but pheochromocytomas are catecholamine-secreting tumors, meaning they make epinephrine and norepinephrine, and they can be a cause of secondary hypertension. To diagnose a patient with resistant hypertension. To find out if they have this, start with a 24-hour urine collection for catecholamine metabolites. Then, if it's positive, imaging studies, including CT scan or MRI, can be done to see it. Sometimes it can be seen by ultrasound. Then adrenal biopsies need to be taken, and if positive, then surgery to remove the tumor to cure the disease. MEN, or multiple endocrine neoplasias, come in two types, and the second has two subtypes. MEN1 is the most common of these, and they're genetic disorders with defective tumor suppressor genes. Pineal gland tumors will affect melatonin production, which helps with light and dark cycles. This will cause potential blockages of CSF and may need a shunt placed to reduce CSF pressure. Headache, nausea, vomiting, seizure, memory, and visual disturbances may be present. You may be asking yourself right now, what is diabetes? Well, I will answer this burning question for you right now. Diabetes is a disease or disorder that causes polyuria polydipsia. It comes in two basic forms, diabetes mellitus and insipidus. We've already covered diabetes insipidus, which is relatively rare. We will now be spending some time on one of the leading causes of morbidity and mortality in the modern world and people, and that is diabetes mellitus. Diabetes mellitus is a disorder of glucose metabolism, meaning that patients cannot process glucose as they should, either from a lack of insulin or insulin receptors that are not effective or insensitive. Type 1 diabetes is due to a lack of insulin, while type 2 is insulin resistance. There is also gestational diabetes of pregnancy. You can also develop type 1 diabetes due to recurrent pancreatitis. Diabetes is an epidemic level disease, mainly type 2 diabetes, as obesity is out of control. Sedentary lifestyles are also playing a role, as many Americans just sit and eat and watch TV or their phones. There are genetic components that lead to this, but a lot has to do with lifestyle choices when it comes to type 2 diabetes. Most diabetic type 1s know they have it, as the symptoms are so severe, while most type 2 diabetics do not know they have the disease, as their symptoms are much milder at first until later in the disease process. Insulin is released from the beta cells with that of C-peptide, which breaks away from insulin, which then forces glucose into cells, while glucagon is released from the alpha cells and brings glucose out of the cells and mobilizes new glucose through the gluconeogenesis. Together, the two regulate glucose metabolism and make a negative feedback system, as we just studied many times before, all to maintain homeostasis. Somatostatin may play a role in this with glucose absorption at the gut, but it's still being studied. How does insulin work? Do you remember this from AP2? Insulin, like all hormones, must look for a target cell with its receptors on its surface. Most cells have insulin receptors, as insulin forces glucose into cells. This is important, as wandering glucose in the serum can cause damage to cells without adequate glucose. The cells begin to starve and go into ketotic state or starvation state. Insulin is released from the beta cells of the pancreas and are released in response to rising serum glucose levels. Glucose is essential for us to live. We need it to help us make ATP. We cannot make glucose on our own like plants, so we have to consume food which we can turn into glucose. We can store glucose as glycogen or fat and break this down when we lack glucose so we can mobilize it. All fairly well fed, but what would happen if you did not have any food to eat? Eventually, your glucose will start to run low. So the body turns to other sources of glucose if you are not able to find food to digest. Glycogen from the liver is the first to be broken down in a process called glycogenolysis. Then fat is next, followed by body proteins. And finally, in an effort to keep the brain alive, the body begins to make ketones. This whole process is known as gluconeogenesis and is how we survive for a time without food to a starvation ketotic state in a normal person. Now, what would happen if you had type 1 diabetes and you could not get the glucose as it does not come into your cells, as there's no insulin to force it in? Then the body still goes through the same steps even though there's ample glucose in the serum, and it keeps building and building. When the type 1 diabetic gets to the ketosis stage, then they make scores of ketones to feed the brain, but this drives them to an acidotic state as it keeps going and going. Then they enter diabetic ketoacidosis. Diabetic ketoacidosis is how several type 1 diabetic patients will present since they lack insulin. They'll have a ketotic state like they are starving despite eating and being hungry. The amount of glucose in their blood rises, and the kidneys cannot remove enough to stop the process, and the patient becomes dehydrated from the kidney's attempts at normalizing the glucose levels. Meanwhile, the body is thinking it's starving to death as glucose is still not in the cells, just out in the serum. So the gluconeogenesis steps are taken until ketones are made as a last resort to keep the brain alive. But so many are made that the serum becomes acidotic and decay has commenced. Again, this only happens to type 1 diabetics or those diabetics that lack insulin. DKA is treated in the hospital, and the goal is to break the starvation state cycle by the first replacing fluids and giving IV insulin. This will force glucose into the cells and feed them. They will then, in turn, stop making ketones, and the fluid replacement will help get rid of some of the excess glucose as well. Most DKA patients recover quickly once the cycle is broken. If they do not seek medical help, they will die. As diabetes mellitus type 1 patients gets older, you have to watch out for overhydration, especially if they have heart failure, cirrhosis, or chronic kidney disease. Type 1 diabetics are generally young people with thin and may present with DKA, as we showed you before, but may also present with a sports physical or with symptoms of polydipsia or drinking a lot, polyuria or urinating often, or polyphagia, which is eating frequently. Type 1 diabetes are insulin-dependent diabetics, which means they do not make insulin for themselves, usually from an autoimmune attack on the pancreas. Most diabetics with type 1 diabetes do not have a genetic background to it, although there are some genetics that can be involved, like if there are autoimmune diseases running in the family, for example, like RA and lupus. There can also just be one diabetic type 1 in the entire family. They're completely insulin dependent, so they must watch their glucose levels closely. Unlike type 2 diabetics who make insulin but are just resistant to it, they will die if their glucose levels drop too low, or if their levels get too high, they can go into DKA and do not seek medical help. Some teens are guilty of insulin purging due to fears of weight gain. Normal glucose levels should be around 70 to 100 milligrams per deciliter fasting. Hypoglycemia is less than 70 milligrams per deciliter. Hyperglycemia is considered above 200 milligrams per deciliter. When taking a glucose tolerance test, this is considered positive at greater than 200 milligrams per deciliter. 2 positive fasting blood glucose levels above 126 will get the diagnosis of diabetes, and 1 greater than 200 fasting. In type 1 diabetes, this will be an easy test to fail, but the numbers get trickier in type 2 diabetes and gestational diabetes, which is also related to type 2. Metabolic syndrome is basically prediabetes, if you hear that term. It's not quite type 2 diabetes yet, but on the way there. It is important to know as you can change the patient's course and keep them away from type 2 diabetes by changing their lifestyle choices. Here are the criteria. A large waist circumference greater than 102 centimeters in men and 88 in women. That is 40 inches and 35 inches respectively. Elevated triglycerides, low HDL, elevated blood pressure, and elevated fasting glucose above 100 milligrams per deciliter. Type 2 diabetes mellitus is a disease of insulin resistance, meaning you have insulin, and in fact usually more than most, but are resistant to it as the receptors on the cell surface do not respond correctly. These patients are typically older, larger, or obese, and have few to no symptoms at first. Type 2 diabetes mellitus is again due to insulin resistance. It has the same polydipsia, polyphagia, and polyuria seen in diabetes type 1, just less severe at first. As the disease progresses, the symptoms become more apparent. Most patients with diabetes mellitus type 2 do not know they have it until it's very late stage. The disease can begin with a prediabetes stage called metabolic syndrome, which is when a patient has a large waist circumference, overweight, hypertensive, hypercholesterol, and a host of other factors that increase the risk for becoming a type 2 diabetic. Diabetes is diagnosed with two fasting blood glucose levels above 126 on two occasions, or one occasion of 200 milligrams per deciliter or above, or an oral glucose tolerance test above 200 milligrams per deciliter. DKA does not occur in diabetes mellitus type 2 as insulin will prevent ketone formation, but rarely some terrible type 2 diabetic patients will get hyperosmolar hyperglycemic syndrome or HHS. HHS or hyperosmolar hyperglycemic syndrome is a rare condition of type 2 diabetics who are in poor control. It causes a large hyperglycemia without ketoacidosis. The patient is actually very volume contracted due to the kidneys trying to get rid of excess glucose, and the patient has severe metabolic alkalosis as a result. This is another life-threatening hospital requiring emergency. You need to again start with IV fluid hydration and not the IV insulin, as adding insulin first will force glucose back into the cells and the water will follow along with it by osmosis. This will cause the volume contraction and hypotension to worsen. Replace electrolytes as needed here, like in DKA. With type 1 diabetes, you need insulin right away, along with a good diabetic diet and education on how to use insulin, etc. Type 2 diabetes mellitus is treated with lifestyle modification first, just like hypertension and hyperlipidemia from week 4. You have to build trust with the patient, and giving them 50 pills to take on the first day seeing them will not build that trust. Only after they make changes, then you add metformin or glucophage, unless their diabetes is very late stages. There are other medications you can add, like sulfonylureas, like glipizide. They need to check their blood sugar or blood glucose a couple of times a day at least. Most insurances will not pay for 4 times a day unless they are on insulin. All diabetics, both type 1 and type 2, need to keep these goals. Keep blood pressure less than 130 over 80 millimeters of mercury, LDL less than 100, HDL greater than 60. Consider aspirin therapy of high risk. Keep BMI less than 25. Quit smoking and exercise 3 times per week for at least 30 to 50 minutes. The diabetic diet is about low carbohydrates and eating consistently, as patients who eat randomly each day have hypoglycemia or hyperglycemia. The diet usually shows a plate like this and what the meal should be made up of. This one from the CDC has 1/4 starches, 1/4 lean protein, and half vegetables that are non-starchy. The dessert is a small plate of fruit. See how they emphasize small? This is a problem with many diabetics, as they think they can eat all the fruit they want as they are taking in large amounts of fructose, which can be then made into glucose. The diet should consist of foods that take different amounts of time to make into glucose. The fruit will be quickly converted, and the starches next, then the lean protein and non-starchy vegetables. This will allow the body to have continuous glucose release rather than all at once, like if they ate a big bag of candy. This is especially important in insulin users to prevent hypoglycemia episodes. Recently, in the last 20 years or so, the Incretin System was discovered. It is a system of hormones released around the GI tract that help to increase insulin and decrease glucagon for type 2 diabetics, and drugs like Byetta help to mimic these effects. Let's take a second to compare the two types to make sure you understand their differences and similarities. Type 1 patients are generally young, as it used to be called juvenile diabetes, and type 2 are older and adults. There are some genetics to type 1, like if your family has a running autoimmune disease, then it can increase risk. For the most part, it's not very genetic, and there are maybe just one in the family. But type 2 is very genetic, and most will have it in the family. The cause of type 1 diabetes is usually an autoimmune attack on the beta cells of the pancreas, although there are a few other rare cases too. Type 2 is a genetic disorder of decreased insulin sensitivity, as the insulin receptors are not functioning properly. There is no insulin in type 1, while type 2 has a lot of insulin and, in fact, is hyperinsulinism usually. Body type in 1 is thin, type 2 is overweight to obese. The consequences are the same, but they are much faster in type 1. Progression is fast in type 1 and slow in type 2. Type 1 is about 5% of all cases of diabetes mellitus, while type 2 makes up 95%. Most type 1 diabetics know they have it, while most type 2 diabetics are unknown. History should include if they have polyuria, polydipsia, polyphagia, family history for diabetes, numbness or tingling in the limbs, loss of vision or blurry vision. Physical examination is difficult in type 1 as they are thin usually and look healthy many times. It is caught on the urinalysis if they still have some insulin left to keep them out of DKA. With type 2 diabetes mellitus, these are obese. They have metabolic syndrome, large waist circumference. They may have acanthosis nigricans, as seen here, which is from hyperinsulinism. Other physical exam findings may include prolonged wound healing and ulcer formation, diabetic skin spots, which are hyperpigmented areas, lipoatrophy, which can occur at insulin injection sites. Labs are important for diabetes diagnosis, especially in type 2. You may catch glucose being elevated on a fasting basic metabolic panel and then repeated if it is above 126 milligrams per deciliter. You need 2 fasting glucoses above 126 milligrams per deciliter or 1 above 200 milligrams per deciliter for diagnosis. Urinalysis can be a clue, but not diagnostic as it used to be. A positive glucose and ketones on a urinalysis done for a physical exam can lead you to a fasting glucose. The oral glucose tolerance test is mainly used to detect gestational diabetes, which is like type 2 diabetes in pregnant women. HbA1c or hemoglobin A1c can be used to measure the glucose levels over a 3-month period and not usually used for diagnosis, but can lead to a fasting glucose test if elevated. If really elevated, then it can be diagnostic. Normal HbA1c is around 5.5%, and diabetics need to keep theirs below 7.0% to avoid many of the complications of diabetes. Gestational diabetes is diabetes mellitus during pregnancy. All women are screened for this, as untreated it can cause macrosomia or large babies. Risk factors are the same ones for type 2 diabetes or metabolic syndrome. Prior history of gestational diabetes, obesity, and large BMI or body mass index, family history, prior macrosomia, advanced age, smoking, and any sign of metabolic syndrome. Screening is done with the oral glucose tolerance test, drinking a glucose-rich liquid, then doing some subsequent glucose testing to see how the body handles large amounts of glucose. A number above 200 milligrams per deciliter 2 hours postprandial is indicative of gestational diabetes. Diabetes causes damage to the body if left untreated. Type 1 will progress faster than type 2, but both will progress nonetheless. Damage from glucose deposition starts in small blood vessels, then works its way to larger ones. It damages small nerves, then larger ones too. This leads to atherosclerosis of the arteries and neuropathy of the nerves. Poor wound healing is also a complication, as the presence of glucose slows down the wound healing process we spoke about earlier in this course. Hyperglycemia also weakens the immune system. It makes the diabetic patient susceptible to pathogen attack. Diabetics can go blind due to retinopathy, lose feeling in their legs with peripheral neuropathy, lose control of their bowels, lose control of their heart, and be unable to sweat, which is called anhidrosis, and problems emptying their stomach, which is called gastroparesis, due to autonomic neuropathy. There are higher risks for heart attacks, strokes, kidney failure due to diabetic nephrotic syndrome, as we discussed in week 6. Diabetics can have neuropathy of the legs, which can keep them from feeling their feet and legs. They can step on toys or hard objects and not even know it. They should always wear diabetic shoes to prevent this, and to get them these shoes, you have to do a yearly diabetic foot examination to prove they have neuropathy. If a diabetic foot ulcer forms, it is very difficult to heal and may benefit from hyperbaric oxygen therapy. Diabetic foot ulcers can become osteomyelitis, which is a bone infection. We will talk about more in the future week. Diabetic retinopathy can lead to blindness, and this is another reason to get diabetics in good control. Yearly retinal eye exams should be performed by an eye professional for the diabetic. There are surgeries that can be done to help if there is progression of this disease. Remember, the retina is the only place in a living human You can look at on physical examination and see a real working arteries and assess their vascular status. Insulin therapy for diabetics should mimic natural insulin secretion as much as possible. Type 1 diabetics always need insulin therapy, and some type 2 diabetics begin to burn out their beta cells over years of insulin hypersecretion and then begin to need insulin therapy. There are short-acting, medium, and long-acting forms. The goal is to get the patients the simplest dosage with the best results without causing hypoglycemia. This can be tricky as diabetics seldom ever eat consistently or correctly. Hypoglycemia is a complication of using insulin. This problem is why most diabetics do not take enough insulin, as they fear hypoglycemia. It can be a terrible experience with confusion, sweating, tiredness, pallor, anger, and other symptoms. Hypoglycemic events in diabetics often occur due to diet changes. It can also be from accidental doses of insulin or even intentional overdoses. Any glucose serum level below 70 milligrams per deciliter is hypoglycemia, and there are several ways to help. If outpatient, they can be using lifesavers or orange juice. But if an inpatient in the hospital, then the fastest is D50 or dextrose 50% IV push. Glucagon subcutaneous would be the next fastest route. Hypoglycemia can also occur in the hospital when the patient's diet is much better than it is at home, and their usual dosages of insulin are given. Nocturnal hypoglycemia can be asymptomatic, which is worrisome in itself, but many times it can cause nightmares, night sweats, confusion, anger, and irritation, headaches, and fatigue upon wakening. Now let's look at some interesting nocturnal hyperglycemias we see in hospitalized patients. For the exam, you need to know the differences in these two. The Somogyi effect is just hypoglycemia event that occurs in the middle of the night that will then cause a rebound hyperglycemia by morning. This is common as the body will try to maintain homeostasis with glucagon release along with cortisol to push the gluconeogenesis activity into higher gear. Dawn phenomenon is harder to understand but deals with a patient who makes a lot of cortisol. This may be some cortisol secreting tumor or just the natural release of cortisol. This drives the blood glucose to hyperglycemia by morning's dawn. Insulin pumps do the best at mimicking the release of insulin from the pancreas. They should be used in type 1 diabetics who are really good at giving their insulin and are active and are on excellent diets. They are a convenience and a tool to give insulin better and not an artificial pancreas that will cure a non-compliant diabetic. To get a patient one of these, you must prove they do not make any endogenous insulin. This can be done by checking their C-peptide level of the serum. Remember, C-peptide is made with insulin and is normally at a 1-to-1 ratio with insulin. So a C-peptide of 0 will show they cannot make insulin for themselves. You cannot use insulin level as they are still using insulin, and this will be artificially inflated, and you do not want them to stop taking insulin as they could go into DKA. Here are some review questions for you. A man's wife was found dead by the police, and they suspected foul play. The man is a type 1 diabetic and uses insulin, and the wife had a strange puncture mark on her backside. She was not a diabetic and had normal glucose levels. How can you prove to the police that the man killed his wife using a large dose of insulin based on your knowledge of diabetes? Can you solve this crime? What is your answer here? The answer is to check the victim's serum insulin level and C-peptide. If she received exogenous insulin, then she will have a much higher insulin level than the C-peptide, which is released in a 1-to-1 ratio. This would prove the means of this murder. A 45-year-old male patient with normal height comes in to see you as they have noticed their hands and feet getting bigger over the past couple of years, along with their forehead. They also complain of vision loss in the temporal visual fields. You decide to order a CT scan of the patient's head after examining him. He asks you, why this test? What is your best answer? What is your answer here? The answer is that the patient likely has a pituitary tumor as he is showing signs of acromegaly along with the bitemporal hemianopsia. Remember that the pituitary is right over the optic chiasm and a tumor can easily suppress this. A 25-year-old skinny female presents with heart palpitations, weight loss, leg cramps. She has exophthalmos on a physical examination. You palpate her neck and feel a large nodule and look at it with ultrasound. The serum TSH is very low. What is the best way to determine if this nodule is a quote-unquote hot nodule causing her disease? What is your answer here? The radioactive iodine reuptake scan is how you can tell if a nodule is hot or cold, meaning does it make thyroid hormone? The patient has obvious hyperthyroidism, and if you can isolate it to a solitary nodule that can be removed, then you can preserve the patient's thyroid so they do not have to take thyroid hormone replacement if you have to burn out the entire thyroid with radioactive iodine treatment. An 18-year-old female presents to the ER with abdominal pain, nausea, and vomiting, and she denies any past medical history as she does not get checkups. On exam, she appears very thin and sick with generalized abdominal pain when palpated. Her labs show a glucose of 800 milligrams per deciliter and positive serum ketones. ABG shows a pH of 7.22, and urinalysis shows large glucose and large ketones. You start IV fluids and then IV insulin. What is your diagnosis? What is your answer here? This is a type 1 diabetic as she's young, thin, and obviously insulin requiring. She is presenting with DKA or Diabetic Ketoacidosis, as many with this condition do. A 55-year-old female presents with polyuria, polydipsia, and polyphagia that has been worsening over the last couple of years. She has rheumatoid arthritis, has been on oral corticosteroids since she was around 35. On exam, she is very obese, has a round moon face and a buffalo hump on her back. Her fasting blood glucose is 225 milligrams per deciliter, and her HbA1c is 10.1%. What are her diagnoses? What is your answer here? The answer is type 2 diabetes mellitus and Cushing's disease. As the patient has been on oral steroids for a very long time, these steroids cause changes to her body, increasing her risk for diabetes type 2. Byetta is an incretin mimetic. What will it do in a patient with type 2 diabetes to lower glucose? What is your answer here? The answer is that it raises postprandial insulin levels, which lowers glucose levels in the serum. It is the end of the week 7 lecture. Now get some rest.